Welcome, everyone, to the Novo Nordisk Network for Healthy Populations seminar series, the 1st of January 2026. So happy New Year, everybody, and thank you for joining us. My name is Lorraine Lipscomb, and I'm the director of the Network for Healthy Populations. Before we start our seminar, I just wanted to take a moment to acknowledge the land on which we are residing and on which the land, the region of Peel operates, given that our rounds are coming from the University of Toronto Mississauga campus. So we'd like to acknowledge that the land on which this region operates is part of the treaty lands and the territories of the Mississaugas of the Credit. And for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're thankful to have the opportunity to work on this land. I'm also personally grateful to this land that has provided me a place to live, work, and raise my family. And I recognize that this privilege comes from the stewardship and care of the Indigenous people who have lived here for millennia. So thank you, everyone, for joining. Welcome. And it gives me great pleasure to welcome our speaker today, Dr. Rayzel Shulman, who's going to speak on improving transitions to adult diabetes care. Before I introduce Dr. Shulman, I'd like to quickly just review some housekeeping items. So we appreciate the audience muting themselves during today's presentation. There'll be an opportunity for questions at the end of today's session, and we'll be inviting questions both with the raise hand feature, but also through the chat box. And I also want to make note that today's session is being recorded, and we will make the recording available on our website for those who couldn't make it or you wanted to review it again. So now I'd like to introduce you to our speaker today. Dr. Shulman is a pediatric endocrinologist at the Hospital for Sick Children in Toronto, and she's also an associate professor in the Department of Pediatrics at University of Toronto. She's a scientist in the Child Health and Evaluative Sciences program at Sickkids Research Institute, as well as an adjunct scientist at ICES. Her research program, which she's going to talk to about today, is focused on developing and evaluating health services interventions to improve health outcomes and quality of care for youth living with diabetes. An area of focus has been the transition to adult care. She holds research funding from the Canadian Institutes for Health Research and Diabetes Canada. So without further ado, I'm going to pass the mic on to Dr. Shulman. Please go ahead.
Thank you so much, Lorraine. Thank you for the invitation and the opportunity. Are you seeing the slides without the notes right now?
Yes.
They look okay? Okay,
presentation mode. Perfect.
Okay, excellent. Okay, so I don't have any relevant disclosures to talk about today. The objectives for the talk are firstly to recognize what are some of the challenges around transition from pediatric to adult care. And then we'll examine some opportunities to improve transition care. And then finally, I'm going to highlight some transition care studies that I've been involved with and are upcoming. So just to start off with, by means of background, emerging adulthood is the time in life from approximately age 18 to 24, during which people are undergoing rapid changes in many aspects of their lives. So these might include aspects of like changing relationships with parents and caregivers and peers, taking on new economic demands like having part-time or full-time employment for the first time, and moving from secondary to post-secondary education or college, and overall just accepting more responsibility for themselves generally. And there's often a mismatch between the level of developmental maturity and these new expectations being placed on emerging adults in various spheres of life, but also by diabetes healthcare professionals who are supporting these young people in managing their diabetes. And so these competing priorities and these increased challenges of diabetes self-management probably explain, at least in large part, the observation that diabetes management is often at its poorest in this age group compared to other ages. So looking at glycemic management across the lifespan, these are data from a US pediatric type 1 diabetes, a US type 1 diabetes registry, including close to 16,000 individuals with type 1 diabetes. And this graph is showing hemoglobin A1C here on the vertical axis and age in years across the lifespan on the horizontal axis. And so what you can see is that hemoglobin A1C as a measure of glycemic management is really highest or poorest right at around the age when people are transferring to adult care. The good news is that this seems to improve rapidly throughout the 20s, but this time of poor glycemic management confers an increased risk of long-term diabetes complications. And also this poor glycemic management is associated with an increased risk of acute diabetes complications. So thinking about these, there is known to be gaps in care around this transition age. And Dr. Garvey in the United States reports that about 20 to 30% of individuals reported having more than 6 months between their last pediatric and their first adult visit. And in terms of the increased risk of diabetic ketoacidosis, or DKA for short, and severe hypoglycemia, Dr. Miranda Nakla, who is now in Quebec, but at the time was studying data from Ontario, and also Capella et al. From Germany, found a higher rate of DKA and severe hypoglycemia in the time shortly after people transferred to adult care. So what do we know about what adolescents perceive as some of the challenges around transition? So again, Miranda Nakla in Quebec, along with Jennifer Ladd, set out to understand some of the perspectives of adolescents in their final year of pediatric care in order to inform transition care delivery in their program. So they conducted semi-structured interviews with adolescents, and they found a number of themes. The first is that adolescents often find challenges with navigating changing relationships with their parents and their healthcare teams. Secondly, adolescents recognize that there is a need to improve their diabetes self-management, but also reported differing levels of comfort at approaching this depending on how old they were when they were diagnosed. So people who were diagnosed at an older age felt less comfortable, probably because they had less time to adjust to their chronic condition. Adolescents also perceived that the responsibility for transition preparation is shared between their pediatric diabetes teams and also themselves, and also felt that the preparation should focus not only on diabetes skills and knowledge, but also about how to navigate the adult healthcare system. So a little bit more around adolescents' perspective, Dr. Joseph Lung, who's in British Columbia, did a study to explore adolescents' perspectives on transition program design. And he found that there were 4 themes that emerged from the data. The first one is about individualization. So adolescents wanted a personalized experience, and some people wanted written information, others wanted online, some people wanted group classes, but the bottom line was they didn't think that a one-size-fits-all approach worked very well. The second thing was interconnection. So adolescents wanted transition care to help facilitate a connection with a social support network. So that might be a peer support network or community supports that were available to them. They also wanted the team to address the fact that they may be feeling a loss of a bond with their pediatric team and may be fearful or hesitant about how they might form a similar bond with their new adult team. The third theme is around identity. So adolescents wanted care teams to understand or acknowledge how the world relates to their diabetes. So this is around addressing issues about stigma living with diabetes. And then finally, the last theme is impediment. So they wanted their teams to recognize that diabetes may be limiting and that self-care takes a lot of work. Diabetes is unpredictable and may carry an emotional burden. Okay, so now moving to the pediatric provider's perspective. So our team conducted a survey of transition practices, pediatric transition practices in 35 clinics in Ontario. And Dr. Nakla from Quebec also did a similar study with some centers in Quebec. And this is a compilation of some of our shared results. So the first thing that we noted was that transition practices varied. So some clinics had structured preparation processes, others didn't. Some did some combined visits with pediatric and adult providers together, and others utilized transition coordinators. People or providers recognized that there were challenges around how to help adolescents prepare for transition. Some people felt like adolescents might not feel ready. There was a concern that adolescents might not be able to take on all of the increased responsibility that was being asked of them. They also felt it was sometimes difficult to engage with adolescents in the preparation, often because they didn't have enough staff and resources and time to support the education. And then the last piece was around challenges communicating and getting support from the adult team to whom they're referring. So often transfer letters were either not sent, not received, or not adequate. And pediatric providers expressed a worry that the adult teams might not be able to meet these very specific needs of young adults. That they may not have multidisciplinary team members, or that they have less frequent visits, that young people may have challenges with booking and rebooking appointments that might create barriers to clinic attendance. They also expressed that there was a high risk of follow-up in this age group, and that there wasn't really an easy way to track people who didn't either get connected or stay connected to care. Okay, so what about the adult providers? These data come from a survey that was conducted in Quebec, and also one that was done in the US by Garvey et al. And these were all survey data. So the adults also acknowledged that adolescents and young adults were often inadequately prepared, and believed that pediatric teams should improve the way that they prepare adolescents, but also acknowledged that it's sometimes difficult to engage with emerging adolescents in this way. They also reported that they didn't always receive summaries, and that the summaries they received didn't always include a psychosocial component that they felt was important. They also noted that there were gaps in care, and that they also only a third of them reported having a system for identifying people who are lost to follow up. And then, similar to the concerns of pediatric providers, adult providers reported a lack of resources. Some didn't have a specific approach for supporting emerging adults, and others reported that they didn't have good enough access to psychosocial and mental health supports for this group. So thinking about all these challenges, let's now move to thinking about what interventions have been tried and how effective they are. I'm going to just tell you a bit about results from a systematic review and meta-analysis that aim to examine which specific components of transition programs are effective at improving outcomes after transfer. So this group identified 18 studies, and noted that the programs varied widely. So some used transition coordinators, others had transition-specific clinics, and others had group education sessions. They pooled data only from studies that included a control group, and notably, this was only 4 studies, and they found no difference in hemoglobin A1C at 12 months after transfer. They also noted that the other outcomes that were measured in these studies varied and included things like clinic attendance, severe hypoglycemia, and DKA. So from this, they concluded that really we don't know what the key active ingredients of an effective transition programs are, and that there may also be variation in effectiveness depending on individual level characteristics, and also of the context in which these clinics operate. So since this systematic review was published, I'm just going to highlight a couple of other studies, some of which are Canadian, to talk about. There were 2 Canadian studies that tested the effectiveness of including a transition coordinator in the model of care, specifically on clinic attendance as the main outcome. One of them was by Butalia et al. In Alberta. This was a non-randomized control trial, and one from CIHR et al. In Ontario. This one was a randomized control trial. Both found a positive effect on attendance, but notably, the results from the randomized control trial were not sustained beyond 12 months after completion of the intervention. Another study, the Coyote Care Study, which stands for the Colorado Young Adults with Type 1 Diabetes Clinic, is from the United States, and their care model used a virtual clinic visit, and this included both healthcare providers and group visits with other young adults with type 1 diabetes. And what they found was that there was high satisfaction with these group virtual visits, and people who participated noted that they perceived good support as a result of these peer interactions. And they also found that their intervention improved clinic attendance. And the last one to just mention is Get It T1D, which is a study led by Dr. Moran-Nakla in Quebec, which is testing the effectiveness of group transition education. And they've completed their study, and their results hopefully will be published soon. So stay tuned for that. Okay, so I'm now going to move to tell you a little bit about some of the studies that I've been involved with. So the first one is called Keeping in Touch, or KIT for short. These are our team members, and this was a CIHR funded study. It was a transitions and care team grant. So you can see there are many people involved. These are the co-principal investigators. We have a patient partner and research staff, and as well as some collaborators. So the background and rationale for the KIT study included that we knew that text message-based interventions to support adolescents with type 1 diabetes, but other chronic conditions as well, have been effective at facilitating the delivery of educational material and to encourage self-management and building independence. We also know that text message-based interventions in this age group have been reported to be engaging, acceptable, accessible, and cost-effective. And we also knew that almost 98% of Canadians aged 15 to 24 have access to a smartphone. So we set out then to co-design a specifically text message-based intervention to improve diabetes self-efficacy. And we then tested it in a randomized control trial in Ontario and Quebec. The intervention was delivered both in English and in French. The other thing that we knew from the previous work that I just talked about is that adolescents wanted a personalized transition experience. So at the start of the study, we asked participants to complete a readiness assessment. And then all of the text messages that they received were based on their responses to the readiness assessment. And so they received information about topics that they felt less confident about. And we also asked them what information they were interested in learning about, and we sent them messages about those topics. So just tell you a little bit about the readiness tool that we used. It's called READY, and it was a measure developed by researchers and clinicians at Seattle Children's and Cincinnati Children's in the US. And it assesses adolescent self-reported confidence about type 1 diabetes specific knowledge and skills. There are these 4 domains on the assessment. And they did some validation or some study of the results of the administration of this tool in the clinics where it was developed. And in a sample of about 800, they found that overall people reported very high level of confidence on most items, but did notice lowest confidence levels on knowledge about diabetes and alcohol, tobacco, sexual health, and the impact of diabetes on pregnancy. So just keeping those in mind as areas that may be important to ask about and to provide counseling on. This is an example of what the survey looks like. It really measures, people respond to each item on a Likert scale, and higher confidence in somebody's ability to perform each of these skills indicates a higher level of readiness to transition. And the nice thing about this being on a Likert scale from yes, I can do this to no, I haven't even thought about this, is that clinicians can use the results to tailor and prioritize topics to talk about in clinic visits. And they can also follow changes in confidence over time. So the other thing that we did was we wanted to seek out transition resources that were associated with each of these domains and specific items. So this work was led by Dr. Anne-Sophie Brazeau in Quebec, and she conducted an environmental scan of online trusted resources available both in English and in French for transition that corresponded to each of the items on this readiness assessment. And so what you can see on the horizontal axis here are these 4 domains. And then on the vertical axis is the number of resources that they found. So just to highlight a couple things, is this bar here in the diabetes knowledge domain represents the number of resources about complications of hyperglycemia. So that was very well represented. And the other one that was well represented was this one here, which is in the health behaviors, which is carbohydrate counting. Some of the areas that had the least number of resources included this one here, which was taking insulin and checking glucose in public. So addressing the issue of diabetes stigma, and also this one about safe sexual practices. And also, interestingly and importantly, in the navigation domain, there were no resources about how to find a family doctor. So then what we did was we used the resources identified in this scan to create content for the text messages in the intervention, which were then delivered using 3 different features. So the first feature is care coordination. So users could tell KIT when they had their upcoming appointment, and then KIT would send them reminders about when that appointment was upcoming and due. We also asked participants to which clinics they were referred for adult care, and were able to send them specific information to introduce that new adult clinic to them. The other feature was personalized education. So as I said, this was delivered on a monthly curriculum, and topics were selected based on the responses to this readiness assessment and what they were interested in. Participants could also request specific frequency and time of day that they wanted the messages to be delivered. And then the third feature is a question and answer feature. So users can ask KIT any question about type 1 diabetes. KIT will recognize keywords in that question and then provide pre-created answers that our study team created using the resources in the environmental scan. Also interestingly, during this study and in response to rapidly advancing artificial intelligence, or AI, we developed an AI chatbot to augment this question and answer feature in collaboration with Center for Digital Health Innovation. And so people in the intervention group were also able to try out this AI chatbot. And they were able to ask the chatbot any diabetes-related questions. And this chatbot was a large language model chatbot, so it would send answers in natural language format and including links to trusted resources. Notably, this chatbot was limited to this curated set of resources that we compiled for it. It was not using the internet. And we did some safety testing to ensure that the accuracy and safety of the responses was good. And this was written up in the manuscript is currently under review. So we also conducted an interim process evaluation that was led by Dr. Laura DeVoe and Roxy Wang at Trillium Health Partners. And they conducted a qualitative realist evaluation with participants in the intervention arm who had engaged with KIT for a minimum of 3 months. And they did some semi-structured interviews and reviewed their engagement data. And we did this specifically to identify early on in the study whether there were issues with engaging users to use KIT. And so they had this initial program theory about the pathways through which they hypothesized that the intervention components might influence outcomes. And then we were going to use the results of this to make any real-time adjustments to the intervention early on if needed. And so the results of this were that they conducted 16 interviews. They found that different components of KIT shaped users' transition experiences positively, but to varying degrees. And the impact varied by specific characteristics of participants. So how long they've had diabetes, what was their baseline knowledge, their access to resources and information, and their baseline level of diabetes distress. And they also found that the impact occurred via many different interconnected mechanisms. And so what we learned from this is that digital supports really need to be tailored, and that there may be some individuals who may benefit more from these interventions, specifically if they've had a more recent diagnosis or have lower levels of baseline knowledge or self-efficacy or higher levels of diabetes distress. Now, we're also planning an end-of-study process evaluation to identify the specific paths of engagement, so which components of KIT might be more likely to produce positive trial outcomes. And they're going to use a coincidence analysis to try to identify some of these potential paths using both user engagement data and also our outcome data from the trial. So we've done also a little bit of work on analyzing some of our baseline data so far. And Stephanie Lynette, was a fellow at the time, but is now a pediatric endocrinologist at Montreal Children's in Quebec, used some of these baseline data to examine the association of self-reported ethnicity and transition readiness and self-efficacy. And so she did multivariable linear and logistic regression models, adjusting for sex, diabetes duration, hemoglobin A1C technologies, and socioeconomic status, and found ethnic disparities in specific aspects of transition readiness and self-efficacy, specifically on the READY assessment with navigating how to obtain our medical insurance and coverage for supplies and medications, and in the diabetes self-efficacy tool about discussing diabetes management with the medical team. We have completed our randomized control trial. We had 6 pediatric centers, 4 in Ontario and 2 in Quebec. Adolescents participated if they had type 1 diabetes within 4 months of their planned transfer to adult care. And the intervention was over a 12-month period. Our main outcome is the mean score for self-efficacy for diabetes management at the end of 12 months. And we are going to be analyzing our final study data shortly, so stay tuned for the results. But I can tell you that we had 234 individuals randomized, and we've got 190 that we have data for and are analyzing for our primary outcome at 12 months. Okay, so moving to another study to tell you about. So KIT was really focused on an individual intervention, whereas this next study I'm going to talk about, called Bridging the Gap, really targeted healthcare professionals. So this was also a CIHR funded study. This is our team. So these were the other principal investigators, our co-investigators, our site investigators. We also did this in collaboration with the Ontario Pediatric Diabetes Network, and we had a number of study staff and a master's student as well. So the main aim of Bridging the Gap was to test whether an audit and feedback-based intervention improved diabetes management for youth in the first year after they transferred to adult care. So audit and feedback is a well-studied quality improvement approach to improve the quality of care by providing healthcare professionals with iterative feedback reports that encourage reflection and action. And so that was the first thing that we did. We had 5 clinics participate, and we provided them using survey data of individuals who were near transition age at their clinics, and reported about, amongst other things, which activity youth felt were most important to cover before transfer and which ones of those were completed. And then what we did was we encouraged each of the diabetes teams to reflect on their feedback and to choose a quality improvement initiative that was guided by a GOT transition framework. And I'm just going to flip to the next slide to show you a bit about this GOT transition framework. So this is a widely used evidence-based framework to support transition from pediatric to adult healthcare generally. It's not a diabetes specific framework. There are tool sets that are linked to each of these core elements of transition. So first, they recommend having a transition policy, a way to track and monitor people, to assess readiness, to plan for the transition, to do the transfer, and then to document completion of transfer. They also have implementation guides to explain how to integrate each of these elements into practice. And finally, they have measurement and evaluation tools to assess how well practices are doing in implementing these supports. So we asked the teams to reflect on the audit and feedback, to use this framework, to do some kind of one or more transition and quality improvement interventions related to one or more of these core elements. And this was a quasi-experimental pre-post study. And then we evaluated outcomes in the youth that were receiving pediatric care at these clinics, and participants entered the study at the time of their final visit. And then we measured outcomes 12 months later after they had transferred. And then we also created a parallel control cohort using administrative healthcare data. So those were individuals about to transition to adult care, but who were receiving care at clinics other than the ones that were not participating in the study. So what did we find? So we found that our intervention improved glycemic management and prompted adaptations to these QI initiatives that they undertook. And 1 year after transfer, hemoglobin A1C was lower by 0.41% compared to participants who transferred before the intervention. And 3 out of the 5 clinics adapted their QI intervention in some way during the course of the study. We also identified important gaps in transition care that were reported in surveys by adolescents. So 67% of the youth said it was important to them to meet their new adult provider before they transferred, but only 11 reported that it happened. 90% expressed wanting to discuss about how to obtain and pay for diabetes supplies, and only 32 reported that it happened. So thinking about these, and there were a few others as well that are in the paper that you might want to think about focusing on, because we know these are things that are important to adolescents. We also, Dr. Janet Parsons did a process evaluation and interviewed members of diabetes teams that participated in the study, and found that the participants appreciated the flexible site-specific approach to the QI initiatives. And they also found that the feedback reports and resources we provided were useful, acknowledging that this happened during the COVID-19 pandemic, which impacted transition care provision and the implementation of the study. But they reported that they, as a result of participation, they changed their transition practices and appreciated that they had new opportunities to collaborate with other diabetes teams in this effort. So what did we learn from Bridging the Gap? I think there were a couple things that we didn't do in Bridging the Gap that we're taking forward to our next initiative. That is that we need to better engage with youth. We need to better engage with the adult diabetes professionals and our community partners. Bridging the Gap, as I said, was a non-experimental study design. It was a before and after. So we want to maybe think about using some more rigorous methodology in assessing the effectiveness of a future intervention. We want to capitalize on the momentum and enthusiasm of these participating sites in the Pediatric Diabetes Network to improve transition care and outcomes. And we have a newly launched provincial pediatric diabetes registry, and we want to leverage the data available in that registry in future work. So this is the last study that I'm going to tell you about. The name is yet to be confirmed, but it is essentially a youth-engaged transition community of practice study. Our team, this is a CIHR team grant, Healthy Youth Team grant, so big team. These are our principal investigators. We have a couple youth partners, and Ethan, I see that you had signed in, so thanks so much for being here, Ethan. We have our research staff. We have some knowledge users from the Pediatric Diabetes Network and Born, which hosts the Pediatric Diabetes Registry, Knowledge Mobilization Champion, and then Community Youth Organization, Patient Engagement Organization, and Diabetes Organizations. And so the rationale for this new study, as we learned from Bridging the Gap and other people's work, that audit and feedback only works if healthcare professionals use the feedback to develop sustainable plans for improving care. And we also learned from Bridging the Gap that audit and feedback works best when it's paired with discussion and action planning through communities of practice. And we know that communities of practice are often used in healthcare for the purposes of sharing resources, providing training, and building practice-based social networks. These typically include healthcare professionals, and there's less known about if examining the effect about including and engaging with youth in communities of practice to improve transition care. And we also know from our previous work and others that youth often feel like their priorities are not reflected in transition care. So taking all that into account, the main aim of this new study is to understand if including youth in a community of practice together with audit and feedback improves transition outcomes. So the first aim is that we're going to co-design the audit and feedback and a youth-engaged community of practice. Secondly, we're going to test whether this intervention improves readiness to transition in a cluster randomized controlled trial in the Pediatric Diabetes Network sites in Ontario. And then thirdly, understand how the intervention components were implemented, what the mechanisms of change were, and what was the influence of contextual factors. And briefly, for the co-design, the aims and the methods, This part of the study, this co-design, is going to be led by Dr. Ian Zenley at the Trillium Health Partners. And he and his team are going to use integrated community-based participatory research methods and human-centered design methods. The first activity is going to be to recruit youth with type 1 diabetes, healthcare professionals, caregivers, and researchers. They're going to form a project advisory board. They're also going to hire and train youth peer researchers to work alongside the research team and as part of the research team. And they're going to engage all these individuals to build capacity. The second activity is to identify what are the youth priorities for transition care. So they're going to do this through some knowledge exchange events. And to the end of this, they're going to identify what are the priorities for transition care activities. The third activity is to co-design this youth engaged community of practice and audit and feedback. They're going to do this through an activity called a hackathon. And then lastly, they're going to co-design training materials to facilitate the implementation of the community of practice. And then they're going to, they'll do this through a series of workshops, and then they're going to validate the training materials as well. So the audit, just a word about the audit and feedback. We're going to use data from the new pediatric diabetes registry and also link to provincial health administrative data to populate these. We will include an initial report using aggregated data from patients who transferred to adult care 12 to 18 months before we start the intervention. And then during the intervention, there'll be 4 reports every 6 months that include different measures about transition. But the details about which metrics will be included will be confirmed during the co-design with youth feedback. The idea is that we're going to encourage diabetes teams to use these reports, reflect on their practice, make changes in their transition care approach, which should also ultimately improve transition readiness and other outcomes. And then for the trial, so again, this youth community practice will be co-designed. So all the details about how often the sessions are going to happen, what's going to be talked about, the length of format will be confirmed in the co-design. And we're going to recruit youth facilitators for these sessions, both adolescents and young adults. We'll also engage and recruit a pool of adult healthcare professionals from the adult clinics to where youth are referred. And then each session will be led by or facilitated by one adolescent and one young adult facilitator that are selected from our pool. And we're going to limit the number of healthcare professionals in each session to ensure that there's a balanced representation of youth and professionals to prevent power imbalances. Because these sessions, for that reason, may be small, we'll plan to repeat topics and provide summaries to ensure that as many healthcare professionals can participate as possible. The mechanism of action that we hypothesize through which these are going to work is that the sessions will support healthcare professionals by sharing resources, which will eventually lead to improvement in the quality of transition care that they deliver. And involving youth will also ensure that youth priorities are addressed in transition care. So we are hoping to include in the trial all 35 of the pediatric diabetes education programs in Ontario. We're going to do a covariate constrained randomization to ensure balance of the different types of clinics in each arm. The control arm will receive audit and feedback only, and then the intervention arm will receive audit and feedback plus participation in the community of practice. 12 to 24 months after the start, we will measure at the patient level our main outcome, which will be the confidence in knowledge domain on the readiness assessment. We're going to use the updated, newer version of the READY, which has just been released. And secondary outcomes will include other domains on the READY assessment, measures of glycemia, and then data from provincial administrative data about what happens post-transfer, so adult clinic attendance, and then acute diabetes complications as well. We have an embedded process evaluation that's going to be led by Dr. Nicola McClary, who's an implementation scientist here at Sickkids, to understand how the intervention was implemented, explore potential mechanisms of change, and identify contextual factors, and assess the impact of participation in the community of practice by youth themselves. She's going to do surveys and virtual interviews with healthcare professionals and virtual focus groups with the youth participants. So what are the take-home messages from all this? I think to say that we still don't know what the key active ingredients of transition care are. We know that there is not a one size fits all approach that's going to work. We can use existing transition guidelines and adapt them in a context specific way to conduct quality improvement in research to improve transition care. And then use of a readiness assessment tool can help with personalizing and individualizing transition care by focusing on areas that are priorities for an individual. So that are all my slides. I'm happy to take any questions. And I'll just stop sharing there.
Thank you so much, Dr. Shulman, for a fantastic presentation. Really, congratulations on all this work. I think it's so important. I'm going to open it up first to see if anyone has any questions. Just raise your hand, or I can see everyone. We're a pretty small group, so if anybody wants to go ahead,
I see
Elena.
Dr.
Dr.
Zenli is here
Wiseman.
too.
Great talk, Rayzel, and really such an impressive body of work. So congratulations. I'm wondering, like locally, we know on the adult side that there are a few diabetes centers that have clinics targeting the young adult population specifically for diabetes. And I'm wondering if anything is known in the kind of real world outside of a study perspective, whether there's any difference in care or outcomes for the young adults transitioning to those centers versus kind of just anywhere more broadly.
Yeah, so I can't off the top of my head cite any specific studies, but I think it's also very tricky because I think the individuals that get referred to those specific centers are also very different from the people who get referred to other centers. And those centers are often located, like we have two in downtown Toronto, in academic, urban, large centers. So, I mean, we certainly are hoping, as I had said, to engage with the pool of the adult healthcare providers. So, if people from those centers, but also from others, are able to share their experiences as well, so that any potential benefits that patients are getting from being in those specific young adult centers can then be shared and be of benefit to people who are not at those centers.
Sure, thanks.
Thanks, Dr. Wiseman, for your question. And some of you may know that we have a transition clinic at Women's College Hospital that I attend, and we actually have a shout out to one of our endocrine fellows, Dr. Priya Bapad, who's actually doing a fellowship this year in that program. I think she's joined us today. Anyway, she's going to be looking at some of those questions. And I know Dr. Shulman and Wiseman, you guys are involved, so stay tuned. Felix.
Hi, good afternoon. I stumbled on this presentation, but I'm so glad I did because at Scarborough, we're just starting to have communications around transition of pediatrics into the adult population. So I was just hoping, would you be able to share your resources and the slides for today? But great presentation. Thank you so much.
Thanks for joining, Felix.
Thanks. I believe that my slides and presentation are going to be available. Is that right?
Yeah, so we post the presentation on our website, Felix. And if I guess, Rayzel, if there are any kind of links to, if there's any reference to some of the resources that are available on your slides, then
yeah, for sure. There's a link to the GOT transition framework, and then there's also we published the environmental scan transition resources. So if you go to that publication, you can see those. And if you don't have access to it, if you email me, I can send it to you.
Thank you. Other questions? Comments? While people are thinking, Dr. Shulman, I had a question for you. So, one of the things that we hear sort of anecdotally from our patients who are in our transition program is that they appreciate the non-judgmental sort of communication approach that we have that we all have adopted, the four of us clinicians as well as all of the allied health. And it may seem obvious, and obviously for any patient, we should be non-judgmental and we should be patient-centered and supportive, particularly with people living with a condition as intense as type 1 diabetes. However, we find in this population particularly, the one of the barriers that keeps them from coming in is if they feel like if they know they're not doing well, and they feel like if they're just going to come in to be reminded and told that they're not doing well, then that keeps them from coming in. And our goal in our program is to make sure that they come back. And so we purposely avoid those kind of conversations, which is counter to what we're told in the guidelines, which is you have to make sure that you identify areas for improvement and you talk to your patient about that. So my question, I guess it's a long comment, but my question is, has there been any literature or research that looks specifically at training or communication styles and how that might favorably impact or negatively impact this population if in fact we're de-emphasizing, glycemic management, for example?
Yeah, I think it's a great point. There was a thesis done, Janet Parsons supervised a thesis project around sort of like the lenses, how adolescents and young adults viewed their diabetes care. And some of that, I think, maybe came out around in those results. I can try to look that up and share it. But I think that's exactly the point of why it's important for us to do this co-design in this upcoming study. So to have both healthcare professionals, but also youth sharing their perspective, because to balance exactly those two issues that you're talking about, and then to figure out how should we message to healthcare professionals, what is the ideal way to communicate, what is the balance of addressing the concerns about glycemic management, but at the same time facilitating an environment and a context in which young adults want to and are willing to come and to have these conversations. So hopefully through Dr. Zenley's work in the co-design, we'll be able to address that exact issue in the community of practice.
Yeah, no, I think it's great work, and I can see an opportunity, for example, for like a training module or something for adult endos who would be taking these patients on, not just endos, but all out adult healthcare providers who would be taking patients on in the transition. But we've currently, through the University of Toronto endocrine program, we offer a communications course for how to communicate with patients with diabetes. But I feel like that's very general, and this would be a really important kind of more specific intervention that could really help. Yeah. Any other questions, comments? I'm not.
I found the reference for that paper that I was thinking of, so I'm just putting it in the chat there.
Thank you. I remember that if that's the one where they had the three
eyes of diabetes integration in emerging adulthood. Yeah, exactly. So how to identify individualized diabetes care.
Mm-hmm. Yeah. Thanks. Thank you for that, Felix.
I really love the idea of the chatbot and sort of prompting it and teaching it, using a RAG model and adding sources in the back end to sort of train it to respond based on guidelines. How did you find the uptake was with that? What was it being utilized? Did the kids like that, or the adolescents?
Yeah. So it's a great question. It was very poorly used, which was a big disappointment. And unfortunately, we hadn't built in any plan to do any interviews with participants to understand why they did or they didn't use it. But I think that's work that Dr. Cafazzo at the Center for Digital Health Innovation, and their team there is going to explore going forward about how to improve and understand, what are the factors that might lead people to use it and benefit from it.
Yeah, no, it's great. Gives me some ideas. Any other questions for Dr. Shulman?
Yeah, I just had a question. This is Priya,
Ahead,
the diabetes fellow at Women's College. I really like the text message interventions and the AI bot because that's kind of what a lot of our adolescents are using a lot of the time. But I wonder if is there a role for like using social media? Like a lot of um, patients come to clinic and say, "Oh, I saw this on Instagram or TikTok or YouTube." And I find sometimes the resources are not always reputable. Sometimes it's like American influencers that have access to different technology and pumps. And so just wondering if that's come up or something that you've come across before.
Yeah, so I think that was one of the things in the co-design of the kid intervention that was identified is that people wanted trusted resources. And so a lot of the things on social media, they didn't know, right? What's the validity of it? But obviously those are the platforms on which young people are engaged. So we actually use, so some of the links to the resources through KIT are actually YouTube videos, for example, but ones that our research team had vetted. And again, using this AI chatbot, but constraining the chatbot to use only resources that are curated is another way to improve the trustworthiness of the resources that are being delivered.
Great. Thanks, Dr. Shulman. Definitely fantastic work, really cutting edge, really important. And we really appreciate you joining us today and taking the time to share your work, share your thoughts, and shine a spotlight on this great work. And in fact, also being done with our partners at Trillium Health Partners. Nice to have Ian Zenley here today, too, one of our good friends of the network. So just great work, everybody, on this initiative. So with that, I'd like to thank everyone for joining today. And thank you again, Rayzel, for speaking. Please ensure that you complete today's evaluation. It's really important for us to be able to maintain our CME accreditation. And the CME accreditation standards do require us to collect the feedback from participants to ensure that our activities do meet your learning needs and improve practice and uphold the highest quality standards. So our next Healthy Population seminar will be on Tuesday, February 17th, since the Monday, which is our usual day, is Family Day. But it will be at noon and it will be virtual. And we're really excited that we'll be joined by Doctors Lisa McCarthy and Ileana Lega, who will be presenting on work that they're doing around diabetes in the elderly. So please keep an eye out for the flyer. Registration will be opening soon, and you can find all those details on our website, and we will be posting the presentation from today there as well. So wishing you a lovely rest of your week, and thank you everyone for joining. Have a great day.